Well, good morning, everybody. Thank you for attending. I don't know what's happening. It seems like every time I give a talk recently, I'm drawing first presentation, and since I work with lots of surgeons, that's usually very early in the morning. So what I'm going to talk about today is using sequencing to understand prostate cancer and to really move it into molecular diagnostics. And to start, I'm going to tell you a little bit about prostate cancer, and then tell you a little bit about array CGH studies that we've done, to just give insight into why we want to move towards sequencing. So prostate cancer, by the numbers. So in North America, there's roughly 300,000 diagnoses of prostate cancer annually. Most of these are treated with surgery and or radiation, and these are associated with significant morbidities. It turns out that probably 30 to 50% of these interventions could be safely avoided by men if they could trust the accuracy of tests. And if these were avoided, that would save the healthcare systems in North America conservatively $2 billion a year. So this is a lot of money, okay? And that doesn't count indirect. It lost productivity by these guys. Now, castrate-resistant prostate cancer, metastatic prostate cancer, is essentially uniformly fatal and results in about 30,000 deaths annually in North America. So what do we need for prostate cancer? Well, we need biomarkers that can identify men that are candidates for what's called active surveillance. So this is the idea that you have low-risk cancer, so you live with it rather than suffer the morbidities that come with intervention. We need to be able to identify candidates for curative intervention, because often prostate cancer is curable with radiation or surgery. And we need to be able to identify men with occult metastasis, right? So guys that have metastatic disease that's not detectable. We need novel combinatorial therapies, and model systems are needed to study experimental therapeutics and mechanisms of resistance. So a number of years ago, I started working on prostate cancer and asking a very simple question that's related to sequencing. That is, can genomics be used to predict a man's risk of prostate cancer progression and metastasis? And so to do this, we used array CGH, and I assume everybody here knows what that is, so I won't explain it. But what we're looking at was a cohort of tumors at 16 years of clinical follow-up. Prostate cancer, that's very important. So 16 years, half the cohort had no progression. The other half progressed to cancer-specific death. So this is a very unusual cohort. And we just asked the question, if we do array CGH, can we identify markers that will predict who's at risk of progression and who can be safely cured by surgery? So we thought we would get a nice molecular profile and be able to tell guys what their risk was. What you're looking at here is the result of the array CGH study, amplifications on the top, deletions on the bottom, and frequency here. And when we analyzed this bioinformatically, we found a single amplification here on chromosome 11 at the MEN1 gene that predicted a post-operative recurrence independent of stage and grade. So that's important. We were doing at least as well as pathology, but a single marker doesn't do a lot of good in a heterogeneous, in a disease that's both clinically and molecularly heterogeneous. So